Welcome, everyone, to today's episode. And before we dive into what I know is going to be an amazing conversation, I wanted to share a tiny bit of my own journey with pelvic floor health, which is part of why this topic feels so important to me. After the birth of my second baby, that kiddo is 36 now, I experienced a uterine prolapse. That means that my uterus was lower in my pelvis than it should be. After my baby was born, I had this constant, just annoying, uncomfortable sense of pressure, this feeling that something was falling out of me, or like I always had a full tampon sitting in my vagina. And I'm not sure today, like even till today, what led to it, but during that pregnancy, I carried my toddler in a backpack almost daily. I hiked. I just kind of kept being pioneer woman or something like that and doing all the things. Probably not the wisest choice in hindsight. I'm also hyperextensible. So it could be that I have slightly laxer pelvic ligaments than others. But back then, my midwives had no idea what was happening. They didn't have training in it. They didn't have awareness. So I looked it up by myself and figured out what was going on. And actually, it was terrifying because all the things I read were like surgery, 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 pessary, your uterus falling out of your vagina. It was actually really scary. And I also had this deep sense of not just fear, but shame. Like, was I weak? Was I broken? And then, was this permanent? And who could I even talk to about it? Actually, I had heard a story of a woman named Robin Lim, who is a midwife, and she had written a postpartum book, even before my postpartum book. It was a really early postpartum book. And I phoned her, not realizing that she lived in Hawaii. So I called her at like 3 a.m. her time. And she had had 5 babies. And she was this beautiful, fit yoga teacher who herself had a uterine prolapse. Just having one other woman who had experienced it and who also had like other options to surgery was so reassuring. It took me quite a few years to heal it on my own, and by the time I was pregnant again, I did carry a lot of fear with me. And I spoke with a midwife who offhandedly said, "Oh yeah, I know a woman who had that and her uterus came out." And I was like, "Oh my God." So that refueled my anxiety, and I think that's why my third birth took a bit longer physically, but also it was emotionally. I was carrying a lot of worry. So fast forward to today, and I was able to fully recover. I learned a lot about my core and my pelvic floor and why Kegels aren't all what they're cracked up to be, which we're going to talk about. And I don't have issues with it ever anymore, and I'm really grateful. But I will never forget the fear and the isolation I felt and wondering if that was going to be my new normal. So, as a midwife and an MD and someone who's been dedicated to caring for women for 40 years across their life cycles, I've really seen firsthand how pelvic health impacts all of our well-being, our intimacy, our confidence, for some women, their literal ability to go out and not worry where a bathroom is or whether they're going to be leaking or have odor. And so many of you have shared stories with me about struggling with incontinence or pain or not quite feeling yourself, for example, after birth and in menopause. These are real and common issues that deserve thoughtful, compassionate attention. And it's why, again, I'm so passionate about this topic. It's been far too hushed for far too long and hidden in shame. And I am so thrilled to have my guest, Sara Reardon, with us today. Known to hundreds of thousands of followers as the Vagina Whisperer, Sara is on a mission to normalize conversations about pelvic health and empower us as women to take charge of our bodies. As a pelvic floor physical therapist with over a decade of experience, she combines clinical expertise with an amazing sense of humor, breaking down complex issues into approachable and actionable advice. You can find her everywhere, from her kitchen to sitting on the loo in her videos on Instagram. They're really great and so informative. Sara is also a board-certified women's health clinical specialist, pioneering in making pelvic health education accessible. She's been featured in the New York Times, Women's Health, and her Instagram posts are just always spot on. And I know they must be helping countless women feel seen and heard and supported. And she has a forthcoming book, which I think has probably got one of the best titles when you talk about a title for someone's work, and it's called Floored. Sarah's also a mom to 2 young boys, which brings her a deeply relatable perspective on pregnancy, postpartum, and juggling it all. So, Sarah, thank you for being here and welcome. I'm so excited to have this conversation with you.
Thank you. And thank you so much for sharing your story. I think it just
Yeah.
really helps so many people and women see how common these issues are. And I think about you researching this back in the day when we didn't have Google or Siri. And it's just really fascinating to see how resourceful you were. And I'm really glad to hear that you were able to get support and recover and go on to have a third baby, which is
Yeah,
amazing.
and a fourth, and also just be so much more aware of this issue for so many women because I was only 22 when it happened. I was so
Wow.
young. And so I was really like, first of all, completely astonished as to what was happening. And I remember checking myself, right, doing a vaginal exam, and my cervix was just right there. And I was like,
Yeah.
no, this doesn't seem right. My midwives were like, well, you just had a baby a couple of weeks ago. No, this doesn't feel right. And it just all that. It was like a lot of pressure, a lot of
Yep.
aching. If I stood up for a long time, I was aching. I was unsure what physical activities and exercises I could do. And I was really afraid I was going to fall out. And so it was really overwhelming, actually.
I'm sure, absolutely. And you're not alone. I mean, so many
No.
women experience this. And, there are stats that show that 1 in every 2 women who are walking into a gynecology office have some sort of prolapse. So it's actually quite common. And we just, to your point, don't talk about it enough. And the options
Yeah.
that can help.
Yes. Okay. So, Sarah, we have a lot of people listening, a lot of women listening, and you and I know that, even studies show that I'm just like, we don't know our ass from our elbow. That sounds so crass, but we don't actually know our body
But
parts,
it's
right? Like, we
true.
don't know our vulva. We don't know our clitoris. We don't know all the things from our elbow. And really, studies have shown that, Ivy League educated women don't know the names for their body parts down
Right.
there, let alone our pelvic floor. Can you start by just giving in a nutshell what the pelvic floor is and why it's so important?
Absolutely. So, as a physical therapist, I work with muscles, and there are muscles in your body that help do different things, move joints, bend over, and your pelvic floor muscles have so many functions, and we can't see them like we do our bicep or our quadricep muscles. This basket of muscles sits at the base of your pelvis. So, we're all probably used to that bony skeleton of muscles that we see, or the bony skeleton of bones that we think of as the pelvis. You may see them on Halloween pajamas or at an anatomical model in a doctor's office,
So, like the skeleton, if you put your hands on your hips
right?
and imagine that skeleton part, kind
Right,
of like where your fingers are stretching across down to your pubic bone, that
right,
bone right in the front,
right.
and your tailbone all the way in the
In the
back.
back,
Yeah.
correct. And so at the very bottom of that is a basket of muscles, and that's what we call your pelvic floor muscles. And those pelvic floor muscles attached from your pubic bone to your tailbone and then between your sit bones. So it really is like a hammock. And inside of that hammock is your uterus, which you talked about earlier, your ovaries, your bladder, which holds urine, your bowels, which hold stool. And those muscles are working all throughout the day to support your organs. And they also have sphincters that help keep in urine and stool, so your urinary and anal sphincters, and they have the opening to the vagina. So throughout a day, these muscles are supporting your organs, they're keeping in urine and stool, and then relaxing those sphincters when we want to empty. They are moving when we breathe. They are helping support our spine when we're sitting and standing. So there's so many different functions that they have, and yet we don't talk about them. And I was 20 something years old in physical therapy school, and I had a professor who started talking about women's health and pregnancy and then eventually the pelvic floor. And I was going, nobody has ever educated me on this. And this is fascinating. I just felt fascinated to be learning about my own body. And then, as you can see now, 17 to 20 years later, I love educating women about their bodies because just as you talked about an elbow or, our bicep muscle, these are just muscles and bones in our body. And I really want to help demystify that for people and look at it with a little bit less confusion and just a little more openness and that I think will help lead people to getting more help.
So shame also keeps women from
Yeah.
getting help. And you mentioned 1 in 2 women walking into the doctor's office have some form of prolapse.
Right.
We'll talk about what that is. Let's just back up before we get to the nitty gritty of what things are and what we can all do. What do you think is really this deepest source of the shame and why we're not talking about these issues.
I mean, we cover this part of our body, right? We don't even call it by its name. We have nicknames for it. We don't even know the difference between a vulva and a vagina, or that we have 3 openings in these muscles. So I think that there's just a lack of education. And when we don't teach people about something, it sometimes can often feel like it should be hush hush, it should be hidden. We don't even know where to address it or who to talk to about it if we do have an issue. And it's often looked at as just a sexual part of the body sometimes. Like, oh, it's a vagina and there's only one role for it, where there's actually so many different roles for the vagina, including menstruation and pleasure and birth. And there's an actual function to it outside of just sex. But I think we also think of this part of our body as dirty or embarrassing, especially when something's not working, like we're leaking urine or having a hard time holding in gas or stool, or our uterus is falling out. So I think that there's shame and embarrassment that have just been layered into society and a lack of education. And now that there's more awareness about it, I think people are finally realizing that, oh, because this has been shrouded in shame and embarrassment, I haven't gotten help. And so I'm suffering unnecessarily when there actually is something to help treat these issues, which is therapy.
We talked about prolapse and leaking urine, and you mentioned stool incontinence too, when those sphincters aren't holding stool in. And I think it's just also, like, it's really embarrassing to talk about that, right? Like, babies pee in their diapers, not grown women. You know, we think of very old people leaking urine, but not women in their 40s. But it's actually incredible. The statistics on how many women have some amount of urinary leakage is pretty significant. I mean, as many as 1 in 2 I've heard past a certain age.
It is true. And I think that's the thing, is that I'll ask a patient, do you leak urine? They're like, no, just a little bit when I cough or sneeze.
Right.
Well, that's urinary leakage. Any type of leakage that is uncontrollable, sudden, can't be stopped, whether you're walking to the bathroom or you make a quick movement, that's incontinence. And that will only get worse and increase in severity as we age, because our muscles get weaker, our collagen levels are less, we have decreased hormones. So as we see women getting into menopause and postmenopause, it does get more severe. And as you mentioned, it is also 1 in 2 women over the age of 65 who leak urine, and it's one of the primary causes of admission to a nursing home later in life.
Oh my gosh, I was just going to ask you about that. I was shocked when I learned that. I was working on a project last year, and I read that statistic, and it was shocking to me. Talk about this.
Right. So it's the same thing with fecal incontinence. Leakage of stool and leakage of urine are one of the primary reasons that people get admitted to a nursing home, because it requires care, and you have to have mobility to, change yourself, clean yourself. And it can also lead to chronic infections like urinary tract infections. So without scaring people too much, I think the point is that these symptoms start early, and when we don't address them early, they can exacerbate and get much more severe and cause a decreased quality of life later on. And I always say, like, I don't want to end up in diapers, or if I do, I at least want to know I did everything possible to try to prevent that. But I really want women to live a full life. I mean, we could live up to 40 years of our life postmenopausal.
Yeah.
And I want us to stay active. I want us to go hiking and travel and socialize and, have a cocktail. But so many women stop doing those things because they're afraid of leakage or something like that, where it really does start to impact the quality of life.
Yeah, I did a social post some months back where I was just jumping rope and showing, like, that's a really quick cardio thing you can do at home. And one of the most frequent comments I got was, but how do I do that? I leak pee when I do that. So I wanted to also not be too scary here. And although this probably is very motivating to start doing something about it, a very small percentage of the population actually ends up in nursing care. It's like 8% or less of adults. So it's really small. But the point is that we really want to be thinking about these things, as you said, ahead. So we talked about our lack of education and lack of knowledge about our body parts. Let's talk about some of, let's say, the few most common pelvic floor issues that women come to you for, write to you about on socials, or you're caring for in your practice, your physical therapy practice. And what are some of the sensations or experiences or symptoms women might be looking for to let them know, hey, time for me to maybe think about doing something about
So
this?
I think when we think about, what this muscle does, it helps hold in urine, hold in stool. It has to relax to empty well. It, has the opening to vaginal intercourse, menstruation or insertion of menstrual products. It supports our spine. It supports our organs. So I tell people when they ask, like, how do I know if I have an issue? And I say, if you're experiencing discomfort, pain, leakage, anything in this part of your body, your muscles are likely involved. So with respect to bladder health, we commonly talk about urinary leakage, which is hands down one of the more common experiences we see in our clinic, but it's also frequent urinary tract infections or overactive bladder syndrome, or actually difficulty emptying your bladder. Some women feel like they have to strain or push to get their stream started, or they may stand up and walk away and then dribble a little bit afterwards. Anything with their bowels. So it could be hemorrhoids, fissures, which are little tears in the anal sphincter, but also constipation, which is one of the number one GI complaints in the country, and then fecal incontinence or difficulty holding in stool. And then pain is a big one. I think we often talk about pelvic floor muscles being weak, but I would say as many people have pelvic floor tension. Mm-hmm. And this is when the muscle is tense or tight and it doesn't relax well. And this can lead to pain such as tailbone pain, low back pain, pubic bone pain, but often sexual pain. So painful intercourse, painful tampon insertion, speculum insertion, difficulty inserting anything into the vagina, whether it's for pleasure or it's for function. And I think we don't realize that muscle tension can be causing these. Just like, I get tightness in my shoulders and neck and I start getting headaches. It's the same thing for your pelvic floor. And we see it pop up in that way. So when I tell them like, oh, sex is so painful. And I'm like, oh, this is literally like a muscle spasm. And when we address that, they can get so much more relief. And I think just helping women through that process is really awesome. And then the way what you mentioned is pelvic organ prolapse, which is when that hammock of muscles isn't supporting your pelvic organs as well. So your uterus, your bladder, your rectum, and those muscles start to push into the vaginal canal, and you can often feel a bulge at the opening of the vagina. Maybe when you're washing the area, you feel something kind of protruding. It feels like heaviness or pressure that gets worse at the end of the day, but it can also lead to straining with urination and bowel movements.
Mm-hmm. I'm really glad you mentioned constipation. So many people are just really excited about gut health, which I think is incredibly wonderful. And there are so many people with their cures for constipation, which are great too, like take magnesium, use your botanicals, all the things I do in my medical practice. But one of the things that my decades of work has really shown me over and over is that you cannot cure pelvic floor problems that cause constipation with senna or magnesium. It may help a little, but you really have to address the pelvic floor. Let's talk about how we can know the difference sometimes, whether pain or pressure or constipation is due to pelvic floor issues or whether it's something else.
Well, it's tricky. It's a little bit of the chicken or the egg. It's like, were you constipated and then that caused muscle tension and now it's hard to empty? Or did you have muscle tension and that caused you not being able to empty stools well, and now they're hard and backed up? And so it's a little bit of a cycle. I think what's really important is putting all of those pieces of the puzzle together. It's not just taking magnesium. It's not just drinking a lot of water, getting exercise, but it's also making sure that you are relaxing your pelvic floor muscles well, that you know how to poop properly. I talk about this in my book, is that there's actually a proper way to poop. And
let's talk about this. I have been like a proper pooper for so long, because as a midwife, I feel like I've spent decades talking to women about physiology of squatting to poop and how can we get as close to that safely on a potty as possible.
Right. And this is enter the squatty potty or the pooping stools that you put under your feet.
Yes. I tell women, like I've said, okay, keep a stool. This is before squatty potty existed. I'm like, keep a stool in your bathroom. I mean, I've even, had women, if your bathtub is next to your toilet and you want to put a leg up, there are just so many little ways that we can, even I've had women face backward on the toilet, which doesn't get you squatting, but helps women relax or just reframe the tension that they might experience like in the usual position.
Right. So when you're in the squatting position, it relaxes your pelvic floor muscles to allow your rectum and anus to open up. So it's almost like there's a constant kink in the hose that's holding in all the poop, because we don't want it to be leaking throughout the day, right? We want it to be kept in. But then when it goes to empty, sitting on a toilet, a Western toilet, doesn't relax that muscle. Squatting does. So the way that we relax that muscle is putting a stool or something underneath our feet, or even just lifting your heels up and then leaning forward. And that brings your knees above your hips, and then that puts you in more of a squatting position to relax your pelvic floor. What often happens is two things. One, people have pelvic floor tension, and even when if they're going to the bathroom or even with the squatty potty, they can't relax their muscles well, so they start straining. Well, when you start straining, it leads to weakness of the muscles over time. And hemorrhoids. And that can also lead to prolapse and leakage. So I've seen many women who have never given birth, and they have prolapse, and they think, oh my goodness, this was, I thought you only had problems if you had babies. And I'm like, no, what do you do every day that can put pressure on your pelvic floor? You strain when you poop. And so it's funny because I'll have someone coming in for painful sex and they've got pelvic floor tension. And I'm like, tell me about your bowel movements. And they're like, no, I'm here for painful sex. I'm like, no, but it's all connected. So, teaching someone the proper way to poop, to relax their pelvic floor muscles. If they do have tension, teaching them, squatting or child's pose or happy baby, all stretches to relax the muscles so they can empty better. But, I teach my kids this because many people come in and they've had constipation since they were children, and maybe it gets worse with travel, or it gets worse during pregnancy, or it gets worse with menopause. And so it has compounded, and that can lead to pelvic floor dysfunction.
Do you find that most people are receptive and go out and get a squatty potty, or do you find more people just find a stool around the house and use that? What do people love in your experience?
A little bit of everything. I think people get pretty creative. Some people use toddler stools or their kids' stools in the bathroom that support their feet when they're brushing their teeth. Some people
That's what I did when I was pregnant.
Right.
I didn't have constipation. I was really fortunate, but I didn't want to get hemorrhoids. So
right. Yeah. And you can use a squatty potty. You can use yoga blocks. You can use a sideways garbage can. I think the funniest story is I have someone who's an exotic dancer who was a client, and she told me that she wore her 8-inch platform heels when she was sitting on the toilet, and that's what she used to elevate her feet. I was like, this is genius. Hilarious. But just to your point, the goal is just to get your knees up. And once people do it, they're like, I wish I would have known this years ago. It's changed my pooping forever. And that's really the goal.
So speaking of heels, what do you think about the shoes women wear and pelvic floor health?
So it's interesting because I've seen a lot of chatter online about the shoes that people wear or the jeans that they wear if they're too tight or they're squeezing their abdomen. And I typically say that it's not one thing that's causing a pelvic floor problem. Like if you have a pelvic floor issue and you're wearing high heels, or you're crossing your legs a lot, or you are wearing jeans that are causing you to suck in all the time, that's likely not helping, but it's usually a variety of factors. So I tell people, look at the data points. If you wear heels and you have more pain, hip pain, painful intercourse, tailbone pain, then I would probably make an adjustment. But if you wear heels and it doesn't affect you, then I don't think you need to stop wearing heels.
I just got a pair of heels for salsa dancing. They're
perfect. And I'd rather use salsa dance. It's a little bit of like, how do we want people to feel? And it's, or if you wear heels, do some stretching afterwards that will relax your pelvic floor. So it's just about balance versus a very black and white view of you can't do this or you can only do this.
I get concerned with high heels when I see women adjusting the way they walk to compensate for the heels. And I worry about their low back, their pelvic health, their actual pelvic health, not so much
and their hips.
Floor.
A lot of it has to do with hip strength. So we see people who have weak hips, but then they have pelvic floor tension because the pelvic floor is trying to support everything because they don't have hip strength. So again, I don't think it's the heels that are necessarily causing that. It's probably a secondary issue, but the heels are definitely not helping. So it's just one of those things where I think we always, as PTs, we always pull back and we look at the whole picture of hips and spine and back and abs and even upper body to say, like, where do we need to make adjustments to help this other part of the body, the pelvic floor?
We've talked about two really big phases of women's life cycles, pregnancy, and of course, with that's postpartum and menopause. Can we talk about those two different junctures in our life? So what do you wish every pregnant and postpartum woman understood about her pelvic floor?
I think that I would really love pelvic floor therapy to become integrated into pregnancy care. We know the stats and just our own personal experiences of how common urinary leakage, abdominal separation, low back pain or hip pain, and sciatica. These are such common symptoms that people experience during pregnancy. And this is one of the first phases, I think, for women when their bodies are going through a transformation, and we chalk it up as a society as like, oh, it'll get better afterwards, or oh, that's just part of pregnancy. So we immediately start dismissing healthcare concerns as normal when they're not normal. They're common, but they're addressable. And the data clearly shows if women are experiencing pain or dysfunction during pregnancy, they'll have better outcomes postpartum if they address it sooner. So the other thing I really want people to know is that even if you have a cesarean birth, so regardless of what type of birth you have, vaginal or cesarean, you will experience some changes in your pelvic floor. It doesn't mean you'll have problems, but your pelvic floor stretches just during pregnancy. I always say that we get these text messages or emails that tell us what size the baby is. And in the beginning, it's the size of a lime or an avocado. Well, by the end, it's the size of a pumpkin or a watermelon. And if you put a pumpkin or a watermelon in a hammock, that hammock is going to drop down, it's going to stretch out and get really low. And that's what happens to your pelvic floor just during pregnancy. So regardless of what type of birth you have, if you are experiencing pelvic floor symptoms or pain after birth, even with a C-section, I want you to still know that you could benefit from therapy.
And then we have relaxin too, which also
Exactly.
changes our pelvic floor and our pelvic ligaments. That also contributes to the manifestation of these symptoms and changes.
Right, and
And that
hypermobility.
happens however you birth.
Right, exactly. And progesterone, which causes constipation and strain. So there's just this whole symphony of things that are going on that are really magnificent during pregnancy, but yet when it causes an issue, I really encourage people to get it addressed sooner. And then one of the biggest things, and this is really why I started the Vagina Whisperer over 7 years ago, is that I really think that we are not educated on how to give birth. And it is not as intuitive when we are in a medical facility as we would think. And for years, almost a decade, I was seeing patients who experienced pelvic floor issues postpartum.
Yeah.
And they, similar to what you mentioned, it could have been prolapse, it could have been painful sex, it could have been a C-section, scar restriction, it could have been abdominal separation, but they felt broken in their bodies. And to have gone through such an amazing physical feat, to enter into this new phase of life that is really joyous and celebratory, but also they felt so down and broken. And I was like, there has got to be a better way. And I think that educating people on how to relax their pelvic floor, how to push properly, different positioning options, even with an epidural, how to prepare their perineum or their pelvic floor prior to birth, can really benefit women, because then once you're under the fluorescent lights and you've got a whole team of medical providers, you kind of can connect with your body because you've done it before, versus in the moment when they're telling you push or do this and you're like, I don't even know how to do that because I've never done it before.
Absolutely. I have a whole lesson in Mama Pathway just on gentle pushing and how to breathe through. And there's so much, it's almost like Valsalva pushing, the hold your breath, curve like a C, and push as hard as you can until your blood vessels are popping in your face, is so baked into every movie. And it really happens like that in the hospital.
I know.
Like, you've got 6 people screaming at you, push, 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 count to 10, push, push. And that is not necessarily the physiologic way to get your baby born. So talk to us about just a few things that women can do in the moment to relax their pelvis, or even prepare ahead of time, what you feel are great tips for pushing.
Throughout pregnancy, I encourage a lot of pelvic floor strengthening and stability work. And then during the third trimester, or the second half of the third trimester, I really start encouraging women to focus more on relaxation, because we want the pelvic floor muscles to be relaxed, to open up, to almost get out of the way, to allow baby to come down the birth canal.
I always say path of least resistance.
Right. And we want less resistance. And the way we get that was nice, lengthened, soft pelvic floor muscles. So I often tell people to do a lot of yoga stretching in the third trimester, such, a deep squat, again, child's pose, happy baby, kind of lunges on the birth ball, walking. When somebody says, what's the best exercise for your pelvic floor? I'm like, walking, just move, right? Get mobility and blood flow to the area. And then I do teach women how to push. So I have them take a handheld mirror or there are these catheter mirrors that you can get on Amazon. And I tell them, okay, I want you to do a Kegel, and you should see your pelvic floor or vagina kind of close up. And then I want you to push or bear down as if you're having a bowel movement or pushing at a baby. And you should see the vagina open up, the perineum, which is the area between the anus and the vagina, kind of push towards your feet. And try that in different positions. Try it on your back. Try it lying on your side. Try it in hands and knees. And see if there is a position that feels like you can do it better. And then try it with holding your breath, and then try it with breathing. And so I have people practice all of this so that they can practice those strategies. So when they actually go to birth, if they have an epidural even, they're like, oh yeah, I remember that lying on my side felt really comfortable for me. Or, I really felt like I did better breathing when I pushed versus holding my breath. And just, I always say it's like we don't run a marathon without training. So
it's like creating muscle memory, literally.
Creating muscle memory and teaching people how to connect with this part of their body. I mean, I think so often I've had women go in to birth and they're like, they were telling me to push and I thought I was doing it, but they just told me I was doing it the wrong way. Yeah. Well, I'm like, well, nobody's taught you and they weren't teaching you. So, I really just want to support women during that process, because I think so often we come out either with physical trauma or emotional trauma, and I just want to minimize that as much as possible. So, and then I do teach perineal massage. The research is mixed on it, but there are no negative side effects. And I think that it's often something women do for perineal scar tissue restriction after birth, once the scar is healed. So I'm like, listen, get comfortable with your body, relax your pelvic floor, stretch your perineum. There's no negatives. Yeah. And if anything, it will help you feel more empowered going to birth.
And then in labor, as much of just gentle support or hands off rather than massage during labor, because that doesn't seem to help. Actually, that may have some
correct. So the research does show during birth a hands off, or what they almost call hands poised approach. So no perineal massage. You can put a warm compress or a warm
That's what I like, a warm compress just
over the perineum.
Like, it's not counter pressure, but it's almost just that warmth is soothing and can help you relax.
Yes, it
does.
And
it gives you a direction, like you can feel somebody there, so it gives you a direction to like breathe
push against
out toward. Yes.
Yeah. And and these are such simple things, and I'm going, these should be standard practice. There are no negatives and there are plenty of positives. And I often think a healthy baby is absolutely the result that we want postpartum, after birth. But we also want a healthy mom. Yeah. And I think making that a priority is essential during pregnancy and birth, so that we don't have moms who don't want more kids or, are suffering afterwards when some things could have been prevented.
And what are your thoughts? Well, first of all, I want to back up and say, I don't love the term Kegels. I mean, I know it's named after Dr. Kegel, and all respect to Dr. Kegel, but I just am so tired of women's body parts or things that we do with our bodies being named after men. So I like to say pelvic floor. You too? Yeah. Yeah. So I usually say pelvic floor exercises, but my thoughts on this have really changed over the decades. Really early on, it was like Kegels were everything. Do Kegels while you're pregnant. Do Kegels postpartum. But then I do think there's been so much more awareness of that importance of contraction and release, and really emphasizing that release. Also knowing, are you someone who does have more pelvic tension or more pelvic laxity? So what's appropriate for you? But in general, for postpartum, particularly for women who have had vaginal births, but also for women who have just had that stretching in pregnancy, and even if they had a C-section, but they have that sense of things being more open, looser. Yes. They want to feel like they're toning back up again. What are your thoughts for postpartum, just routine postpartum pelvic floor care?
So I actually have in my exercise platform, I really walk women through week by week of how to address this, because in the first 4 weeks, I kind of want you to chill. I do encourage doing some gentle pelvic floor contractions, also known as Kegels, throughout the day. And a lot of that is just to pump blood to the area, to reconnect mind to body, to help minimize swelling, just to wake those muscles up. Mm-hmm. And then once you hit that 4 to 6 week mark, I do encourage doing some strengthening, starting with some of these exercises like bridges or a ball squeeze between the knees or a pelvic floor contraction, and then eventually building strength back up into squats and lunges and rebuilding core strength and hip strength that has been compromised because we've been supporting a growing baby. if you start experiencing pain or you have painful sex or any other symptoms associated with tension, I'm like, let's pause and let's do a few weeks of stretching and relaxation, and then let's pick back up the strengthening. So it's a little bit of a combination of both and a little bit individualized. But I agree with you. I think that just reconnection to this part of our body is really important. Strengthening is really important, as is mobility. I want you to walk. I want you to do some stretching. But I also want women to know that they have to be proactive about it. These muscles don't just kind of, spring back together the way that they did prior to pregnancy. And I talk about this similarly, like if you go through a surgery, a knee surgery, you get your knee fixed, but then you go through really aggressive physical therapy. You go see a physical therapist 2 to 3 times a week for 12 weeks. You get pregnant, go through 10 months of pregnancy, have a baby, potentially surgery, and you go home and you get nothing. And we reframe that to think like you absolutely need rehab after giving birth. That, again, is another time where we just need it to be integrated into the standard of care for women.
The other thing, too, is that I think a lot of women forget or don't know, and providers don't connect the dots on the fact that if you are breastfeeding, you also have suppressed estrogen, and that is not going to help your vaginal and pelvic tissue get fuller and more plump and
toned.
Yes.
That's correct. And we'll see women coming in and they're like, sex is so painful.
Yes.
And I look at their vaginas and I'm like, your vagina's pretty much in menopause because you have no estrogen right now. And they're breastfeeding full time. But nobody has coached them on, if you're going to be pumping or lactating, you're going to have lower estrogen levels, and that can affect pelvic floor tone, pelvic floor lubrication. And again, just these are so common. They're universal experiences, yet we're leaving women in the dark and literally just not giving them these tips of use a lubricant, return to exercise. And even when you go to your postpartum visit, which for midwifery care is usually between 3 to 6 weeks, in standard OBGYN visits, it's around 6 weeks.
Oh, girl, my midwifery care was like first day postpartum home visit, third day postpartum, 7-day postpartum, 10-day, and then 2 weeks back in my office.
Oh my goodness.
It was so intensive. It's so important.
And I wish that was the care model, and so, which is why a lot of people I think are opting towards midwifery care, because it is such a hands-on and supportive approach. But the point is that we go to that, say typical medical visit. 40% of women don't even go to that postpartum visit. But if you go, it sometimes doesn't even include a physical exam. You get a thumbs up to return to sex and exercise, maybe a conversation about birth control, and that's it. So say you return to exercise and you have prolapse, or you have leakage, or you return to sex and you have pain. There is zero follow-up for moms to get continued support. And that's where I think it's just, there are so many more touch points that are needed to really help women get back to where they need to be after birth.
I have to tell you, the coolest exercise that I found for myself when I was struggling with that prolapse. And as I said, I had this when I was 22. I was already practicing as a midwife, and I was, still reading so many books that were coming out. And there was this incredible woman, you may have heard of her. Her name was Sheila Kitzinger, and she was a British, kind of the matriarch of childbirth education. She was a home birther herself, just kind of like almost like a Julia Childs kind of British woman, and although I guess Julia Childs wasn't really British, but she had that, like kind of proper bearing like that. And this way of speaking. And she had a book on childbirth education for childbirth educators. And in it, she had this pelvic floor exercise called Happy Birthday. And it took some practice, but here's what it is. It's a little wild, but it's easier to do it to start lying on your back. So I started doing it lying down, like in the morning when I woke up and then before bed. And then I would stretch out one time during the day to do it. I would then learn to do it in a bridge and then learn to do it standing up. Here's what it is. You're imagining that you're writing happy birthday in cursive, so in script, starting at your vaginal opening with the H in lowercase letters. So you're like H curls, A curls. So in your mind, you're using your pelvic floor muscles, vaginal toward the cervix, to spell happy birthday. And then you
This
release.
is fascinating.
Yeah.
I've
Because
never heard this.
it takes you a minute to do, not literally a minute, it takes you like a few seconds to do it, right? And you're really working those muscles in a really like bottom to top way. You're kind of pulling up and you're getting very detailed and you're going kind of like very incrementally and slowly. And then you release and you do it again. So I try to do it 10 times and then doing it in a bridge, first with pillows under my hips, then just like a yoga bridge and imagining that you're doing it. And then ultimately, like I'd be washing the dishes and like, oh, I'm going to spell happy birthday 3 times. It was
Amazing.
yeah, it was very cool.
This is the first time I've heard this, and I'm pretty fascinated. I'm going to have to research this. But to your point, I think it helps people connect to their bodies versus, I think sometimes I hear PTs say like, oh, pull your sits bones together or like bring your hip bones in towards your pubic bone. And I'm like, okay, I'm in this field and that's not connecting with me. Right.
I kind of get it. I can do that.
Right. But we're assuming that people know what the parts of their body that, we're asking them to connect with when that's just not always the case. So I actually love that. And I'm going to give it a try.
Yeah, it's very fun, actually. It's because it's very focused. It gives you something to do. It's not just squeeze and release, but you're really very intentional with it. Okay, so we've talked about pregnancy, postpartum, and these are some great tips. And of course, all the things we said about pooping and not straining postpartum are really important. Put your feet on a stool, use a squatty potty, all the things. Fiber too. Okay, we talked about what happens postpartum with estrogen if you're lactating. And now we get to this other stage of our life, perimenopause, menopause, and our estradiol goes down. And estradiol is what keeps everything moist and plump and juicy and firm and toned. And that starts to sadly go away. And with that, we may also experience changes in our pelvic floor and changes in our bladder tone and our sphincter tone. And then if you add to that women who have also been pregnant,
right?
This can be a time of either new onset or worsening, particularly urinary incontinence, sometimes fecal or prolapse. And a lot of this is also just brushed off as normal aging. So let's start, if you don't mind, with talking about what I think of as almost like the preconception to pregnancy, perimenopause, right? This is the yellow brick road that we can follow and do so much during that time to prevent some of these problems showing up. And many women enter perimenopause already with some of these issues. So how can we use perimenopause as a time, if we haven't already, to pay attention to our pelvic floor health, and what can we do?
I've actually started to rethink about how I address perimenopause, because I used to think it's like, oh my goodness, like your symptoms are all over the place and I'm losing my hair, my vagina is drying up, and and I almost think of it now as like, you've got this awesome runway.
Yes, that's what I think of too. Exactly.
You know that your body is going to go through a change, just physiologically, without a doubt. Anybody who is still living by the time they hit menopause will go through menopause. It is undoubtedly going to happen. And pregnancy, giving birth, and menopause are 3 of the biggest risk factors for pelvic floor dysfunction. So going into this season of life, which could last a couple of years to an entire decade, I'm like, this is pretty awesome, because we have a chance to build up our strength, to connect with our pelvic floor, to take care of it, whether we've experienced postpartum issues or pelvic floor dysfunction, or we haven't, and we just want to be prepared.
Yeah,
so
we have
now
so
I'm
many
like,
chances every single day,
Yes,
right? Like
yes.
every single day we can be doing things.
right. And it's interesting because I talk about that in my book, and there people are like, "Oh, I'm in menopause. I don't really need the book." I'm like, whoa. I talk about how to properly pee, how to properly poop, the best postures for sleeping, standing, sitting, driving for your pelvic floor, just things that we do all day that are going to make a difference in your life. And yeah, then we go through pregnancy and postpartum and menopause and pain. But I think that we don't realize that, again, menopause could be 30 to 40 years. I want you to be practicing all the habits during that phase to minimize pelvic floor issues. But perimenopause, it's the same way. So,
I mean, it could be 50 years, right? If you go into menopause at 42 and you live to 92.
right. I know.
A long time.
So there's a lot of conversation right now about using hormones. And I think that it's either using topical hormones or different suppositories in conjunction with other systemic hormones. And that is outside of the scope of what I practice. I'm not a physician or a midwife or a nurse practitioner. And so I really try to collaborate with other physicians who are more knowledgeable in that area. I have my personal thoughts. But as much as we talk about strengthening our muscles and, building up our bone density, and I'm like, we have to talk about our pelvic floor because it will undoubtedly change. So during perimenopause, if you're not experiencing tension, I tell women to start proactively strengthening their pelvic floor because you have to build up that tone and muscle mass, because once you hit menopause, you lose 2% of your muscle strength every year. So you need your cup to be full. You need your muscles to be strong. You don't want to go in at a deficit, an empty gas tank, and then just try to catch up. You want to go in with a full tank. And then if, the gas tank starts to empty a little bit, you can keep doing exercises to keep up. But I want people to be proactive going into this season. And then to also be aware if changes are happening, if vaginal dryness is happening, if more frequent urinary tract infections, if painful sex or leakage occur, then you can start being more aggressive about therapy and pulling things in. But I find myself at 42, the seasons from pregnancy to postpartum to perimenopause all started blurring together because we're having babies later in life.
I'm seeing that a lot in my
Yes.
patients and in the women I'm connecting with online. And
Yeah, I've got, a family member who will be 42 having her second baby. And then I'm like, you're going to be in perimenopause within 2 years.
we had a couple of moms come through Mama Pathway Support Group who were between 48 and 51 having first baby. So they're straddling that too, that
Right.
they're in perimenopause. They're in menopause now,
Right.
postpartum, not knowing if their breastfeeding is what's keeping their period suppressed or
Right.
have they crossed it. It's so interesting.
It's really interesting. But again, I think it's where we want to be proactive and kind of understand our bodies and saying like, okay, what do I need to be doing to strengthen, to keep my tissues lubricated, to, all of these things just to kind of keep our pelvic health optimal.
Yeah. So
prior
what
to
do you think
menopause.
about, I have so many what do you think about, but let's talk about the physical things that women can do, the extras, but I'm so curious about what you think about this concept around lubrication. Like if you don't use it, you lose it.
So I don't subscribe to that. I think that people
don't
can
either.
experience dryness.
Because not everybody wants to have sex. And-
Right. Or they don't like, or sex could be outer course and not inner course.
Exactly.
So, I do think that with respect to muscle tone, the more often you have muscle contractions, whether it's an orgasm or whether it's even arousal, just bring blood flow to the area, that does help with tissue strength, that does help with muscle strength.
Absolutely.
So if that's the goal, then I'm like, absolutely. But I don't, with lubrication, I'm more worried about it causing pain, tissue tearing, infections, things like that, like much more functional than I am that you need a juicy vag to get busy. I think it's really peeps. I have, women who are like, I don't have a partner and I don't need to have sex and I'm fine. I'm like, what are your goals? Like, they're like, I want to stop leaking. I'm not worried about intercourse. I'm like, okay, well, that's what we
I don't want to be
work
on antibiotics every 6 weeks for another
Exactly.
UTI. I hear that a lot.
Exactly.
Yeah. So what are the things that women can do proactively during perimenopause and continue to do intimate, like we know what to do for our biceps, right? We know
Right.
what to do for our thighs. What do we do for our pelvic floor?
So you start with really basic pelvic floor contractions like we talked about, almost like you are postpartum. You start with contractions and lying down and then bridges and go into lunges and squatting. But I really encourage women to start using weights just like they do with their squats and their bicep curls, but you're bringing the pelvic floor contraction into that. So before you do a bicep curl, you're doing a pelvic floor contraction and then doing the bicep curl. Before you do a squat, you do the Kegel or pelvic floor contraction, and then you do the squat. So you're automatically turning that muscle on and loading it with exercise. And it's an easy way for people to start strengthening their pelvic floor without having to set aside 20 minutes to do a Kegel workout. And it really becomes functional. Like if you're lifting a heavy bag of groceries, you need to be contracting your pelvic floor. If you're lifting your grandkid or a stroller,
Or your
you need to
kid
be-
if you're 48 and
yeah, if your kid, I have a 7-year-old and I still have to carry him.
Yep.
And I'm 5'2". I'm not so it's like I still contract my pelvic floor. So I think strengthening is important. The other thing is using our breath to minimize pressure down. And I always say exhale with exertion. So if you are lifting weights, don't hold your breath. You need to be breathing out. If you're pooping and you're trying to push you need to be exhaling and pushing out. If you're lifting your kid, exhale as you lift your kid. If you hold your breath or do what we call a Valsalva, that locks all this pressure into your abdomen and pushes down on your pelvic floor. That
That's good
repeatedly will lead
for
to
me a
weakness.
reminder. I always feel like when I'm doing weights, I do tend to hold my breath on the
Yes, a
exertion
lot of
part.
people do.
Yeah.
And we see it online. And we see weightlifters holding their breath and their eyeballs pop out and their face gets red. I'm like, okay, that person probably has hemorrhoids. But it's the
Yep.
same thing. It's pressure doesn't know where to go, so it will go to the path of least resistance. And that is often the pelvic floor as we get older. So exhaling with exertion, proactively exercising, walking is huge. You can build pelvic floor strength just through walking. There are studies that show that. Managing constipation and eating good foods, getting enough hydration, having good poop so that you don't have to strain, also important. And then having good bladder habits, not going just in case. Waiting until you have the urge to go. Don't push when you pee. Again, more pressure. Just sit and relax to empty your bladder.
I also see the opposite where, and I feel like I'm talking to my patients about this all the time, especially those who do have frequent UTIs, is like, how long after you notice you need to pee do you wait? And it's like some women just wait until their bladder is so full
Yeah.
that they're just running to the bathroom. So
They're
don't
running to
wait
the
till you're
bathroom.
so overfull
Yeah.
either.
The normal range is between 2 to 4 hours. So if you're going, and I'm guilty of this at work, if we're seeing patients, sometimes I'll go 8 hours and I'm like, Sarah, you did not go to the bathroom enough,
Yeah.
and my muscles are so tight, I can't even start my stream.
Yeah.
And so I think just knowing some of these habits of, going when you have the urge, but don't go too often. Also staying hydrated. As we get older, sometimes we don't want to leak, so we avoid drinking fluids. And then you get higher concentration of bacteria, you're at risk for a urinary tract infection. So again, just some of these basics to maintain really good pelvic floor health.
That's phenomenal. So I am a huge fan of physical therapy and a huge fan of pelvic floor therapy.
Love that.
And yeah, it's so powerful. And what's really amazing too is the data on the efficacy of pelvic floor exercises to fully reverse or fully prevent the need for pessaries, surgeries, for urinary incontinence surgeries, for pelvic tacks, and like the tack A&P is what they used to call it in the hospital, A&P special, anterior posterior tack, right? And unfortunately, too, some of these surgeries like pelvic mesh, the A&P, they don't necessarily last a lifetime. They sometimes need to be repeated, and they have had some pretty significant consequences.
Right.
So there's huge data, like 80% of women could prevent the need who have significant issues for ever going down that road.
Right.
And a lot of women really benefit from working with a pelvic floor therapist to even just identify their muscles, to know what they need to do. But I think the idea is often intimidating for women. It's very personal. They don't know what it involves. And also for women who have had sexual trauma or birth trauma,
Right.
that can be intimidating. So can you walk us through what pelvic floor therapy is, what it involves, and also how people can find a great pelvic floor therapist?
If you are looking for a pelvic floor therapist, I think there's a couple of different routes to start. One is asking a trusted medical provider. So if you had a patient who asked you, I'm sure you have a handful of therapists that you say, we get really good results from this person, or this is a really great colleague that I have that I could refer you to. Also asking other women. I think referrals are the best when they come from friends, other moms, other menopausal women. So people kind of in your community. And there is so much more open conversation about this now. I'm in a New Orleans moms Facebook group where I live. And so often I hear women going in there or see them and they're like, who's a really good pelvic floor therapist for this or in this area? And it's just awesome that we're able to ask these questions now instead of privately search. And then you can also, there are some directories online. So if you go look up pelvic floor therapists in my area, you'll see some locally. And then there's a website called pelvicrehab.com that you can go to and enter your zip code and find someone. So that's
Any
one way.
credentials that women should specifically be looking for?
I think that there are a lot of great therapists out there that don't have a lot of credentials. I think that I have what's called a board certification, so a WCS, which that is a smaller percentage of pelvic PTs have that, it does let you know that you're working with a more advanced therapist. Like in the city of New Orleans, I think there's 2 of us. So it's really, it just gives you a sense that if they have a WCS, they're experienced. But a lot of this is like dating. I mean, you kind of need to find the right doctor, the right therapist. And I just tell people, if you go to a therapist and it doesn't feel like the right fit, then find another one. It's like trying on pants and saying my pants don't fit, and then you stop wearing pants. I'm like, no, it's not that that physical therapy doesn't work. It just maybe wasn't the right therapist. So when you go see a therapist, typically the sessions are 45 minutes to an hour long. They're in a private treatment room. So they're not in like a big therapy gym like we may imagine physical therapy. And a lot of it is just talking at first. The first session, they're going to ask you a lot of questions about why you're there and about all of your pelvic health, your birth history, your menstruation, your surgical history, peeing, pooping, sex, all the things. And then they'll do a physical exam, some of which will be external, looking at your abdomen and your low back and the muscles in your hips. And then the internal portion of the exam, you undress from the waist down and you put on a hospital gown, or you drape a sheet over your lap and you lie in a comfortable physical therapy bed. And then they do an internal pelvic muscle assessment. And the way that we examine the pelvic floor muscles is through the vagina or the anus. Typically it's through the vagina. So with a gloved finger, they'll insert their finger into the vagina and they'll ask you to squeeze, which is a Kegel. They'll ask you to cough and see if there's any movement of the organs or muscles. They'll ask you to push to see if you can kind of coordinate the muscles. And then they'll test your strength and then test for tension. And all of this gives us information about, if she's experiencing these symptoms and she's got weakness, well, then we need to start strengthening. Or if she's experiencing these symptoms and she's got tension, then we need to start relaxation. So it just helps us define a pathway to help the patients. And again, some of it can be internal work, some of it can be external exercise. So it's a variety of things. And you're also welcome to have somebody in the room with you. We have partners come in, we have doulas come in, a variety of things, if whatever makes a patient feel more comfortable.
And what are your thoughts on biofeedback devices or weighted cones, different things like that?
So biofeedback it's a device. It can be a variety of things, either an internal sensor that's like a tampon, or little external pads that are put around the anal opening, and they pick up muscle activity. So if you Kegel and you see there's a little screen that'll show you what your muscles are doing when you do a Kegel. That can be a really helpful tool for people, because
I find women find it really helpful to be able to have, especially if they don't have a clarity around the sensations
Right.
they're feeling, or aren't sure they're identifying the right muscles. That
Right.
feedback can be visually helpful for some women.
Absolutely. Biofeedback can also be using a mirror, like we talked about, using your hand. So it doesn't have to just be the machine. But if patients have a hard time identifying their muscles, I like to use that. And then, but eventually they kind of move off of it. Because again, I want them to be moving around, integrating these contractions into exercise and function. So they shouldn't be hooked up to the machine every visit, the whole visit.
Yeah.
And then the same thing with weighted cones. I have some patients who are like, I don't like it. It falls out and it just feels discouraging, or I don't want to spend money on something. But I have some patients who are like, oh, this is really helpful to have something to squeeze around. Or it reminds me to contract before I squat, before I lift weights. And so, every patient is different, but these are awesome tools to just have as options. And even to help you do some things at home, that if it helps your compliance, if it helps you be more consistent, then go for it.
Sara, you mentioned that you had some thoughts on hormone replacement therapy, and I know it's not your wheelhouse. We can also edit this out if you're not comfortable talking about it. But I would really love, given how much emphasis there is on hormone replacement therapy, from your perspective as someone who's really working with women in this area, because we do know, right, with significant incontinence, vaginal dryness, potentially even mild prolapse, restoring some tone to that tissue can be helpful, and estrogen or DHEA can help with that. But obviously it's not something all women want to do, and it's not the only answer either. I would love to hear your thoughts in a nutshell, if you don't mind sharing.
Oh, I love this question, and thanks for asking.
Yeah.
What I'm really passionate about is informing women of their options and the pros and cons of all of those options, and then letting them make informed decisions. I don't think that there is one way to do things. I personally am a fan of topical estrogen or DHEA suppositories. it's a pretty low hanging fruit for people to use. They're putting it in the pelvic region, in the vagina and the vulva, and it's going to very locally help plump up those tissues and tone the muscles and improve dryness. And the research is pretty supportive that has a very low, if any, risk on increasing systemic estrogen in the body.
It's very low. I want to add, I also like hyaluronic acid. It doesn't give you quite the bump that the vaginal estrogen does, but some women get great benefits from it.
Yeah, that's another great option. So I think if we can help people relieve these symptoms with something pretty simple, then, and there are minimal to no side effects, I think it should be pretty standard to offer that. If somebody says no, that's fine. But I think we need to offer it as an option because it can help decrease incontinence, and it can help decrease infections of urinary tract infections and bacterial infections. So these are important things for pelvic health.
I just learned that it can significantly prevent night waking in women because a lot of women are waking at night from either urinary irritation.
Yeah.
And that causes them to feel like they need to pee or the actual need to pee frequently.
And it's interesting because one of the signs we'll see with aging is more frequent urination at night. And again, this is like a doomsday stat, but one of the reasons that people end up fracturing a hip or a wrist is because they fall at night.
I've seen this
and the
so
reason
many
they're
times
up
in
at
the
night,
hospital.
right? The reason they're up at night is because they're walking to the bathroom to pee. And so when I think about the positive effects this could have for people, if we can be proactive in it, then I think it should again be standard of care and offered.
Thank you for sharing that.
I think when it comes to more systemic hormones like a patch, or I'm not a fan of pellets.
No, I'm
not a fan of injections. I think it's personal. I mean, I will probably do it, to be honest with you. I'm not doing it now. But again, I think it's a piece of the puzzle. I think we also have to educate women on the benefits of exercise and nutrition and, stress management and sleep along with using hormones. And so I really want this to be a piece of the puzzle. So even if you don't take that piece of the puzzle because you are worried about a risk of estrogen-driven cancers or anything like that, then you've got other pieces of the puzzle to help support you. But I do think there are benefits for those that are using it. But again, to me, medicine is a bit of a practice and an art and an individualized approach. And but I don't believe in do as little as possible for as long as possible. I don't believe in that. I really think I like to be on the proactive side of things and give people options so they're not in the dark and they can be, ahead of things instead of behind.
I love that. In terms of getting pelvic floor therapy, so I know as a primary care doctor, I can do a basic pelvic floor exam. I've done gynae and OB, so I can do a lot more. Urologists can do as well, and then we can refer. But in general, when someone's looking for a pelvic floor therapist and they're concerned about cost, are there people who take insurance?
Absolutely. So just like any medical profession, similar to seeing a psychotherapist or there are, again, physicians who are in private practice and don't take insurance. There are many, many pelvic floor therapists that are in practices or hospitals that take insurance, and there are many that do not. In our practice here in New Orleans, we do not. And the reason for that is because our sessions are an hour long. And the way that insurance companies reimburse you is that they're thinking physical therapy sees 2 to 3 patients at a time in a big gym. So they'll literally give you $30 an hour to see a patient. And I don't want to see a patient.
For physicians.
Right.
It's ridiculous. Yeah.
You can't do this type of work with 3 people at the same time or in a 15-minute session. So it is a frustrating situation for people. And I've often gotten attacked online for it, but I want people to understand that we're really trying to just offer the best care possible with the constraints of the medical system and the insurance system. And it's hard to do this type of therapy in the typical physical therapy with reimbursement rates. And so if they reimburse physical therapy for pelvic floor differently, then that would make it more accessible, but we don't have control over that.
I'm all for that, though. Okay, so for the woman who is listening right now, whatever stage of life she's in, she is pregnant, she's postpartum, she's perimenopausal, menopausal, anywhere in between, before even, and she's feeling overwhelmed or maybe even hopeless about her pelvic health. This is the first time she's hearing that help exists, that she can do anything about it. Where can listeners start? Just today, where can they start to feel less overwhelmed, less hopeless, feel hopeful, and have some tools to get going with.
I mean, the first thing I would say is to follow me on Instagram because I think that you'll.
I follow you on Instagram. I agree.
Because you'll realize that there are 610,000 followers who also want to learn about their pelvic floor because they also didn't know where to go for help or they're learning. And I think it will demystify a lot of things that you may be experiencing and you realize how much more commonly people experience them. So find me at the Vagina Whisperer on Instagram. I think the other thing is you really do need to be an advocate for yourself. You need to approach your doctor or a medical provider or do some research to find a pelvic floor therapist. Like the solution is not going to fall in your lap. So I want you to advocate for it. If you see a doctor who says, nope, that's just normal, leakage is normal with aging, go to somebody else to get a referral. Or some PTs don't even need a referral. I'm able to have somebody just walk into my office and I don't even need a referral from someone. So, I want you to advocate for yourself. I want you to push to get the care that you need because it's not as seamlessly integrated into healthcare like going to the dentist is. But I also want you to be really hopeful because a lot of these symptoms are totally treatable. It takes time and it takes consistency, but it is never too late.
I would say for me, and I was young and I was fit and I was healthy, I would say it was 2 years between when I had my baby and it was a very smooth vaginal birth, gentle pushing, all the things, but it happened anyway. A good 2 years till I didn't feel symptomatic.
Yeah.
And then it was triggered again a little bit with the next births. And then a few years after fully having babies that it wasn't bothering me at all. Mine was minor enough that it wasn't like I felt like I had to go and do surgery or get a pessary. But I'm so committed to how much the happy birthday, much those simple exercises, working on my core, yoga, walking, and just being thoughtful of what I lifted, who I lifted,
right,
and how I lifted. Really.
And how you're peeing and how you're pooping.
Yes,
and,
all the things.
I think that it was funny because even a friend locally, and she commented on an Instagram post yesterday, she goes, every time I pee, I go, WWSD, what would Sara do? And like, would she push? Would she, like,
people say that to me too when they're like having a pregnancy thing. What would Aviva do?
Right.
Someone told me there should be bracelets, which I thought was hilarious. Okay, that's going a little far.
I love that. So I tell this story and I actually share it in my book as well, that there was a day in my clinic that I had a 72-year-old woman who I was seeing for painful intercourse and postmenopausal dryness and weakness. And then I had a 27-year-old woman come in who was, experiencing vulvar pain and painful sex. And it was just this beautiful moment in my waiting room. And they were crossing paths and I'm going, this is literally a woman who's never given birth but needs pelvic floor therapy, and a woman who has 3 babies and is postmenopausal by decades and needs pelvic floor therapy.
And still wants to have sex.
And still wants to have sex. And it is for every season of life, and it is never too late. Even if it improves a little bit or potentially a whole lot, I'm like, you are worth it. The amount of time we spend on other things, we get one pelvic floor, and I want you to take care of it, and you totally deserve to live a full, rich life without having to worry about these things.
Sara, a decade ago or more, a friend of mine who was a midwife in Michigan had dressed up as a vulva for Halloween.
Love it.
She even got hair, like a roll of hair from a hair salon. And it was quite elaborate. And her teenage son, who had grown up with her being a midwife and for whom this was very normal, borrowed the costume and wore it to a school costume party, like contest, and was put in detention and then expelled from the school for inappropriate behavior. And he was not being inappropriate. He really was just celebrating. And it was cute, like the little clitoral hood lifted up and he had eyes so you could see up at that's where the face was. Very, very well done and anatomically correct. And it just feels like, to me, that's such a statement on where we are as a culture.
Yeah.
Again, this wasn't that long ago. It was in the news. It was a big deal.
Oh my goodness.
What you're doing, you have a vulva costume. I've seen you.
I have like 3.
Yeah. And what you're doing is so important to educate women. I'm so appreciative. I have a question that I love to ask each guest at the end of the show, and I'd love to ask you.
Go for it.
If you could tell your younger self anything, how old would she be and what would you tell her?
My goodness. I will be 26 and deciding whether to go right into physical therapy after, or pelvic floor therapy after graduation from PT school, or do I go the safe route of doing orthopedics like everybody does and, kind of playing it safe because I didn't want to specialize too soon. I deliberated on this for months and I chose the right path, but I would tell that woman, you are going to be fine and you are going to make the best decision of your life. Trust yourself. Don't look around at what anybody else is doing. Just put your blinders on and put your head down and do what you love, and you will have the most rewarding career ahead of you.
I love that. It gave me chills.
And it's true.
Yes.
I mean, I think we're all nervous to walk the unknown path. And it's not like you build something out of nothing, but if you pour your heart and your soul and your desire and your passion to just ultimately help people, it just is such a fruitful way to spend my time working. And I absolutely love it. And I feel incredibly fortunate to be doing what I'm doing.
That's beautiful. One of my favorite quotes is by Rumi, the poet, and it's what you seek is also seeking you. And to me, it's just about that alignment, trusting our path. And I love that you shared that you have trusted your path and that your path is helping so many women, including listeners. So thank you for being with me. We're excited about your book, Floored.
Thank
and
you.
We'll shout that out when it comes out. But thank you for all you do.
Thank you so much for having me.
A pleasure. All right, everyone. See you next time.